Welcome to the HTI1 Proposed Rule Impacts for Patients and Caregivers information session. My name is Tom Deneen with Kaufman & Associates and will be assisting with the logistical support for this Zoom session. To ask questions, click the Q&A button at the bottom of your screen. However, please note that there are restrictions to what questions that can be answered due to the Administrative Procedure Act. If you have general comments, please click the chat button, which is also at the bottom of your screen. This will pull up the chat box, which will open to the right side of your Zoom interface. Please use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the Q&A portion of the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. If you need technical assistance during the session, please type the issue into the chat box, and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Lana Moriarty.
Thank you. Hello, everyone, and thank you so much for joining. We are happy to be here today to present to you a summary of the HTI1 proposed rule with a focus on areas or proposals that impact patients and caregivers. You'll hear more about that as we discuss the rule, but first, let me start with a brief overview of ONC as an agency and what we do. Next slide. Next slide. ONC and the position of a national coordinator was created in 2004 through an executive order and legislatively mandated in the Health Information Technology for Economic and Clinical Health Act, or HITECH Act of 2009. ONC is the principal federal agency charged with coordination of nationwide efforts to implement and use the most advanced health information technology and the electronic exchange of health information. ONC is also charged with formulating the federal government's health IT strategy to advance national goals for better and safer healthcare through an interoperable nationwide health IT infrastructure. And as you can see here, we've made a lot of progress since the HITECH Act. In 2009, we were focused on laying the foundation of EHRs across the industry. We had significant investment to subsidize EHRs for hospitals and ambulatory providers, as well as ONC's certification for health IT systems. Moving to the 21st Century Cures Act in 2016, we are leveraging EHRs to drive value. We're defining information blocking and requiring access to information through APIs without special effort. Also requiring nationwide governance for health information exchange networks, or the Trusted Exchange Framework and Common Agreement known as TEFCA. Next slide. ONC has three primary areas of activity, along with our coordination efforts that are intended to further our two objectives. And those are to advance the development and use of health IT capabilities and establish transparent expectations for data sharing. With regard to standards, ONC coordinates, invests in, develops, and promotes programs and policies that lead to greater consistency in how health data is represented. For certification, ONC administers processes for the testing and certification of health IT to specific technical baselines and oversees how developers of certified health IT participate in the market. With exchange, ONC coordinates, invests in, develops, and promotes programs and policies that expand and improve the secure transmission of electronic health information. But a key part of ONC's identity is in our name. It's our coordination function. ONC coordinates with a wide range of stakeholders: government, non-government, federal, state, and local, private and public, for-profit and not-for-profit, to further progress towards our two objectives. Next slide. Under our current national coordinator, these are our four areas of focus. Building the digital foundation. We've spent a lot of time over the last decade investing in electronic health records and putting those in place. And now 97% of hospitals and over 80% of healthcare providers across the country are using certified health records. We know that there are still gaps though, so we want to keep building the digital foundation. The second area is making interoperability easy. We want to do all that we can to create mechanisms and structures to allow for the sharing of information and make sure that it's as easy as possible and reduce the burden. The third area is promoting information sharing, to be able to use those technologies and capabilities to encourage appropriate sharing with patients, with providers, and other important stakeholders involved in healthcare delivery. And finally, to ensure proper use of digital information and tools. Once we've got digital foundations and you're sharing information, how do we add guardrails and expectations to ensure that the information is being used appropriately and in the best interest of the patient? Next slide. Next slide. Now I'm going to talk a little bit about the rulemaking process. The rulemaking process is a set of procedures that federal agencies follow to meet legal requirements for developing regulations. Generally, agencies get their authority to issue regulations from laws or statutes enacted by Congress. And in some cases, the president may delegate existing presidential authority to an agency. According to the Administrative Procedures Act, or the APA, agencies must follow an open public process to issue regulations. A proposed rule, or Notice of Proposed Rulemaking, NPRM, is the official document that announces and explains the agency's plan to address a problem or accomplish a goal. It must be published in the Federal Register to give public notice and to give the public an opportunity to comment. The proposed rule and the public comment received on it form the basis for the final rule. Next slide. The unified agenda is where all federal agencies publish their planned regulatory activities, including us. It is published twice a year in the spring and the fall. The next couple of slides will illustrate how this looks for ONC's HTI1 proposed rule and what will be the ONC HTI2 proposed rule. Next slide. This slide captures how the HTI1 proposed rule looks on the 2022 fall agenda. We obviously changed the name of the rule since publication of the 2022 fall agenda, and the 2023 spring agenda will be updated accordingly. The 2023 spring agenda will likely publish sometime this month and will also include our target publication date for the HTI1 final rule. Next slide. Similar to the HTI1 proposed rule, you will see a name as well as an abstract update for this rule on the 2023 spring agenda. Note that our target publication date for the HTI2 proposed rule is November of this year, which will be here before you know it. ONC is also working with the department on a proposed rule that would identify disincentives for healthcare providers that are found to have committed information blocking by the HHS Office of Inspector General. My colleague Mike will briefly touch on this during the discussion of information blocking later in his presentation. Next slide. So I'm going to talk a little bit about how public comments inform a final rule. The notice and comment process enables anyone to submit a comment on any part of the proposed rule. The agency must base its reasoning and conclusions on the rulemaking record, consisting of comments, scientific data, expert opinions, and facts accumulated during the pre-rule and proposed rule stages. To move forward with the final rule, the agency must conclude that its proposed solution will help accomplish the goals or solve the problems identified, and also consider whether alternative solutions would be more cost-effective or cost less. So depending on the rulemaking record, an agency could terminate the rulemaking, continue the rulemaking with changes to aspects of the rule to reflect new issues, publish a supplemental proposed rule if there are major changes, or proceed with the final rule if changes are minor. Later in the presentation, we talk more about the importance of public comments and how they are shaping the final rules, including providing an example. We will also spend some time explaining how to comment on the HTI1 proposed rule. Next slide. In addition to including requests for information or RFIs in a proposed rule, sometimes ONC just issues RFIs. Early in 2022, we published an RFI in the Federal Register that focused on electronic prior authorization. The RFI included a specific set of questions for the public. We received over 140 public submissions, which included many pages of comments, and we plan to use those comments to inform future regulatory activity. Next slide. And now I'm going to give a general overview of the HTI1 proposed rule. But before we move further, I want to mention the disclaimers for this webinar. Generally, what you need to know is that we will do our best to recite the rules proposals with accuracy. However, the official proposals are in the proposed rule and published in the Federal Register. We also cannot elaborate on or clarify any proposals today beyond what we stated about them in the rule. So if you have questions we can't answer today, please submit a comment. Again, we will go into detail later on in the presentation about how to submit a comment. Next slide. But most importantly, what is the why? Why the rule? And I'm going to focus on how we are relating back to the Cures Act, the executive orders, and how we are leveraging health IT and advancing interoperability. The Cures Act added Section 3009A to the Public Health Service Act for an EHR reporting program. ONC undertook a process over the past several years to implement and fulfill this responsibility. Additionally, the Cures Act required that this program become a condition of certification for health IT developers under the ONC Health IT Certification Program. The US CDI and Fire Corps proposals continue the iterative process of meeting the Cures Act obligation to providing access to all data elements of a patient's electronic health record to the extent permissible under applicable privacy laws. And I also want to touch on APIs, or application programming interfaces, that allow EHI, electronic health information, to be accessed, exchanged, and used without special effort. What we anticipated as being another iterative process continues with this rule as we provide more regulatory certainty for actors and remain cognizant of and responsive to the identification of reasonable and necessary activities that do not constitute information blocking. So moving on to achieving the goals of the Biden-Harris administration and their executive orders. With regard to Executive Order 13994, I think you will find this executive order aligns perfectly with the work of ONC and is exemplified by the rules proposals regarding US CDI version 3 and application programming interface, or API, updates, which Jeff will discuss later in the presentation. Executive Orders 13895 and 14091 show that ONC is committed to advancing equity, and this rule is consistent with the administration's executive orders on the matter. Section 1 of Executive Order 13985 states that because advancing equity requires a systematic approach to embedding fairness in decision-making processes, executive departments and agencies must recognize and work to redress inequities in any policy and programs that serve as barriers to equal opportunity. And I think that you will see this evident in US CDI version 3 and our decision support interventions, or DSI, criterion proposal, which also aligns with the direction of Executive Order 14901. And moving to leveraging health IT and advancing interoperability, the HITECH Act and the HHS Secretary delegations of authority establish certain duties for the national coordinator and ONC, including the adoption of standards and certification criteria and the keeping of the ONC Health IT certification program. Embedded within those duties and various congressional actions is a focus on health data, health technology, and ultimately interoperability, hence the renaming of our rulemaking approach to HTI. You will see this leveraging of health IT and adherence to interoperability throughout this rule and provide requirements of the certification program in the effort to make health data more readily available when and where it is needed. Next slide. The rule generally breaks down into 5 categories, 4 of which will fall under the ONC Health IT certification program. We will not discuss categories 1 and 4 today, which are the new regulatory approach for certification criteria, additionless, or the insights, condition, and maintenance of certification requirements. But if you are interested in those sections, we have discussed these in prior webinars, and I will provide direction on how to find these webinars later in this presentation. My colleagues, Jeff and Mike, will discuss the other categories today. Next slide. And with that, I will turn it over to my colleague, Jeff Smith.
All right. Thanks, Lana. Welcome, everyone. Glad to have you around for another installment of our overview of HTI1. My name is Jeff Smith, and I am the Deputy Division Director for the Certification and Testing Division within ONC. And I'm going to talk about some of the updated standards and revised certification criteria that we're proposing in HTI1. So if you can go to the next slide, please. Okay, so here's an overview of the standards, or at least some of the major standards that we are requiring be updated and adopted as a function of HTI1, as well as a list of the certification criteria that are implicated by these updates. So I think it's important to note that standards are how computers communicate amongst one another. It's literally how one computer can understand what another computer is saying. So these are foundational to what ONC does. The US CDI is something I'll go into a little bit on the next few slides, but this is also just a really important set of data elements. And we're proposing to raise the floor from version 1 to version 3. And I think as a general statement, what we're looking to do across all of our standards, or at least many of them, is raise the floor. And again, that's a really important aspect of what ONC does. It creates the conditions to harmonize so that different systems and software companies can communicate with one another using the same version of standards, or at least are consistent with a baseline version of standards. We'll go into some of those certification criteria in more detail in subsequent slides and try and tease apart why it matters to you in the audience as a patient or caregiver. So next slide, please. Okay, so if you're not familiar, the US CDI is a really important concept, policy concept, as well as technical standard that ONC manages. It was comes from a previous concept called the Common Clinical Data Set. And if you think about it like that, the US CDI does represent a core set of data that all certified health IT are expected to be able to access, exchange, and use consistently. And so these data elements you can see on the right, probably not very clearly because it's small type, but really version 1 is what all certified health IT are required to use and access and exchange today. In HTI2, we are looking to raise that floor to version 3. Now, we've gone through a couple cycles annually to try and identify US CDI data elements that we think are important to add. We've got a lot of public input over those cycles, and then we've updated to US CDI v2, and last summer we announced US CDI v3. So for those that have been paying close attention to ONC and to what we do, what's in US CDI version 3 has been known for a number of months. And what we're proposing is really to raise that minimum floor. And at some point in the not too distant future, we'll be unveiling US CDI version 4. So this is meant to be a pretty consistent process with a lot of public visibility, a lot of public input, so that we can help the industry understand where our priorities are and quite honestly, which data elements are most important to the broadest cross-section of interested parties. So if you can go to the next slide, please. All right, so here's a snapshot of USCDI version 3. I think by way of where the yellow boxes are, you can see where the emphasis policy-wise has been for the administration so far, and that is on trying to further promote health equity. So you can see that there are new social determinants of health data, and there are new demographic data, and then health status and assessment data, as well as health insurance information. So these are, I think we started at just around 50 USCDI data elements with version 1. I think we're above 80 with USCDI version 3. And again, these are the data elements that ought to be routinely and consistently and ubiquitously available for patients and caregivers, as well as clinicians, regardless of the systems that are at play. Next slide, please. Okay, so why is this important? And we'll try and highlight this across a few of these certification criteria and standards updates. So, I mean, I think first and foremost, the US CDI, because it's standards-based, tries to unambiguously represent data concepts. And that means that the data are more accurate and more complete. And we think that this will have a really important impact for all the systems involved, because they'll be able to consistently capture more accurate, more complete patient characteristics. And this can really help drive better pictures of individuals' health and honestly understand outcomes for patients, including those who may be underrepresented or marginalized. We also think that this version 3, as opposed to version 1, will result in better care, better experiences, and better outcomes. Because we've got more granular data and more data elements in version 3, we will just be able to have clearer pictures of individuals' health. And then last but not least, health equity by design has been a major push of this administration, of this national coordinator. And version 3 really does try and emphasize those data elements that would be key to furthering the concept of health equity, considerations that are incorporated from the beginning and throughout the life cycle of software development. And I mentioned some of those on the previous slide. Next slide, please. Okay, so another, I would say, marquee criterion, another marquee aspect of our certification program is our standardized API. And this has been something that the program initially started off with kind of a functional requirement. And then in the Cures Act final rule, just a few years ago, established a standardized API. So before, it was a requirement that was general. Certified Health IT had to support APIs for patient access, but what kind of API, what standard was left unsaid. We have since then created a more standards-based API, and we are looking to build off that standards-based API. So there's a lot of technical jargon in here. I think the big takeaway is that we are looking to raise the floor by relying on newer versions of foundational standards. And so the US CDI version 3 we just spoke to, but there's also the US Core Implementation Guide and the Smart Application Launch Framework. And really across these two standards, they just clarify instructions that are necessary to ensure consistency across implementations. And so various software companies and developers may use the same standard, but they may use it in different ways. And so these implementation guides will help ensure that everybody's reading from the same sheet of music, so to speak. And then we also make some policy clarifications. So historically, we have required that when a patient connects an app of their choice to their health information via their patient portal credentials, the patient has the right to revoke that access. And we've been explicit in HTI2 in saying that a patient, when they request access or when they request this access be revoked, the system has to be capable of revoking that within an hour. We didn't previously have a time constraint on that. And so we're adding a time constraint of 1 hour to that, which is pretty standard across not just healthcare, but across other sectors that similarly rely on APIs for consumer access. And then we do have a technical clarification and set of constraints that we're adding to what are known as service-based URLs or FHIR endpoints. And I'll talk a little bit about those in a subsequent slide. The benefits, I think, are pretty important. The Smart App Launch Framework has a number of privacy and security benefits to it. I'm happy to answer questions about those. Won't go too much into it here. But at a basic level, the Smart App Launch Framework does include a number of things that will enhance privacy, provide more control to users of applications, and set some more guardrails around security that we think are going to be really important. We also think that aligning industry approaches for publishing these FHIR endpoints will enable patients to more easily use apps of their choice to connect to their data. Next slide, please. Okay, so I think the big picture here is improving access for patients and individuals who want access to their information for whatever purpose they want to have that access. These standards will make this concept of special effort, which those of you who've been following this program for a while know that special effort has special meaning when it comes to the 21st Century Cures Act, and it comes to the ONC Cures Final Rule. We think a lot of these standards will enhance and make it easier, this notion of special effort, this notion of plug and play, this notion of I want to download an app and connect it to my patient portal like right away, the way that I could download an app and connect it to other things. We also think that these further reliance on standards will help foster competition in the marketplace. There are specific things in there that should essentially just make more consistent individuals' experiences with accessing and using their healthcare information the way they access and use information in other sectors of the economy. All right, next slide, please. Okay, apologies for the heavy text on this slide. We're trying to get a lot here, and I'll try and slow down just a little bit from talking too quickly on this one, because this is a really important piece of the puzzle that we've been working on for a while, and it's not without pretty heavy levels of complexity. But I think the notion here is that this is the only net new criterion that we're proposing in HTI2, and really what we are proposing is that individuals would be able to leverage their HIPAA right to request a restriction using certified health IT, or certified health IT would facilitate individuals requesting a restriction of their information for subsequent use or disclosure. We are looking to modify a few different pieces of the program. I think probably most relevant is we are proposing to modify what is known as our patient portal requirement. This is the view, download, transmit certification criterion, affectionately known as E1, if you're using ONC regulatory speak. And what we are looking to do is require that certified modules certified to E1, that is to the view, download, transmit, aka patient portal criterion, have the ability to flag data and subsequently restrict access or use of that data based on an individual's preferences. So we think there are some important policy benefits that we hope to achieve with this. We think that generally speaking, this is one way that we could enable users of certified health IT to implement a process to restrict data from use or disclosure in response to an individual's or a patient's request. And this would also support the HIPAA privacy rules right to request a restriction. And I think what's important here is, if you're not familiar with that HIPAA privacy rule provision, worth going back to look at it, I think for our purposes, it's important to note that HIPAA gives patients the right to request. HIPAA doesn't require that the data steward or the provider, usually the clinician, grant that right. So that's another piece of the puzzle. And I think what we're trying to do here, what is important is that we are trying to enable technology to facilitate that process so that a patient can flag a piece of information that they don't want to be sent forward or they don't want to be made available. And then the technology can facilitate a provider from granting that right or not. That's within their purview. So that's kind of it at a high level. If we go to the next slide. There's a few other dimensions to all this, which I think are worth calling out and worth noting. Most notably, we know and have known for quite some time that a lot of what ONC does is propose policies and technology requirements that move data from one place to another. Interoperability being the million-dollar word. And I think we've long been looking at this space, thinking, how can we use technology to be privacy enhancing? And so that's one of the ways that we look at this is how do we mitigate the risks of any unintended negative impacts of individuals resulting from the sharing of sensitive health information. That other piece there, the sensitive health information piece, is another aspect to this. When you look at how the federal government heretofore has addressed sensitive health information, it's had to do so in a very kind of categorical way. It's had to go through a process of defining sensitive data, and then it's gone through a process of saying, okay, well, what can be done with those sensitive data? And one of the things that this policy or this approach would try to do is put back into the hands the decision of what is sensitive into individuals' hands. So we know that the concept of what is sensitive is dynamic and specific to individuals. There could be a range of data elements or information that individual considers sensitive that currently do not have any kind of special coverage outside of any other law or paradigm. And really what we're trying to do here is we're trying to empower individuals to say what they believe is sensitive. And so one aspect of our proposal would essentially say that an individual could choose any US CDI based data element and flag that as being sensitive. And the system would have to register it as such. So we do believe that certified health IT, to the extent feasible, should be able to support covered entities to execute the processes to protect individuals' privacy and provide patients opportunities to exercise this right to restrict. That's the big idea behind this certification criterion. And our proposals go in two different directions. One is standard agnostic. So essentially, can we just tell certified health IT, you need to be able to do this? The other proposal is to be standards based, saying, okay, certified health IT, you have to use specific standards to facilitate, the policy outcome that we've been describing on exercising rights to restriction. There are pros and cons behind both of this, and that's why we're asking questions. So if you haven't had a chance to spend time in that section of the rule, there's a lot there. There's more than one alternative approach. So we're really interested in your feedback on this piece of the puzzle. All right, next slide, please. Okay, a couple of requests for information that we wanted to flag for this particular presentation. One of them is on this concept of smart health links. Now, you might be familiar with the concept of smart health cards. These came into prominence with COVID, and essentially these are the QR codes that were developed in concert with ONC and several other groups, including HL7 and MITRE and a number of others, came together and put together a standards-based smart health card. And I think it's really important to note that the smart health card was a QR code that was standards-based. It wasn't a QR code that you had to pay a private sector firm to to manage. So the concept of a smart health link it builds on this concept of a smart health card. And really, there's a number of differences. I think the best way to think about smart health links is that it's bigger, faster, stronger than a smart health card. The smart health card is good for a smaller amount of information that really doesn't change too much over time or changes very infrequently. And smart health links is more dynamic and is able to carry more information in its payload. So if you go to the next slide, please. So here's the RFI. As I mentioned, Smart Health Links is really intended to allow individuals explicit control over whom they share their health information with. And it includes, generally speaking, the ability to carry more information, more data, and can actually carry data that changes more frequently. So we do have a number of questions. We think this is a really interesting technology. Again, it's standards-based. This isn't a solution that was developed by your favorite identity management firm, but this is something that is standards-based, and we think it has some implications or could have some implications down the road. But we ask a number of questions on really the value and feasibility of implementing this. We do know that there are some complexities around it, but are interested in understanding if the complexities can be overcome or what can be done to overcome those complexities. And then we're also interested in any other kind of industry-led activities that we should consider along with our kind of baseline FHIR standard, which would help improve interoperability. All right, next slide. Okay, we're going to transition here ever so slightly. We've been flying at the 30,000-foot level where we've been able to see a lot of the countryside in a single shot. And now we're going to go down to the 10,000-foot level and zero in on the metropolis that is decision support interventions and algorithm transparency. So if you'd go to the next slide, please. Okay, so we've got a couple slides here that try and give you the really big picture up front. And then we've got a few of the more important details. Again, trying to keep this pretty low at the 10,000-foot level, but also give you the bigger picture. So we think that transparency is prerequisite for instilling trust in the use of predictive technologies and predictive algorithms in healthcare. And that if we can instill trust in predictive algorithms, then they will be used more often. So one of the baseline objectives we're trying to achieve here is transparency, but also trustworthiness towards the optimization and widespread use of high quality predictive models. So we talk about predictive decision support interventions. Think of DSIs as a broader concept than clinical decision support. So it does include clinical use cases, but it could include administrative or public health or other use cases. Our proposals in this section are really intended to improve transparency, enhance trustworthiness, support consistency in the availability of information around predictive DSIs. And this would allow users to determine the quality of the DSI that's in front of them. And we define quality as those predictive models that are fair, appropriate, valid, effective, and safe, or FAVES. And then last but not least, again, with this emphasis on health equity by design, several of our proposals are intended to address bias and health disparities that are potentially propagated by predictive DSIs. And we would like to, again, to shine transparency on the use of several different data types that are salient to health equity so that these technologies can be used in safer, more appropriate, and more equitable ways. Next slide, please. So here's the one slide overview that gives you kind of a picture of our logic model, in addition to some of the details around what we are proposing. So the logic model here is data transparency plus performance transparency on the predictive DSIs, plus organizational transparency on the socio-technical competencies of those firms that develop predictive DSIs will equal trustworthy predictive models and will equal models that are fair, appropriate, valid, effective, and safe. So on the data transparency side, I did mention that several aspects of what we're proposing would enable users to know when a DSI uses social determinants of health data, race, ethnicity, or language data, gender identity data, or sexual orientation data. We think that those are would be good to know if a DSI uses that. So not just a predictive DSI, but really any DSI, if it uses SDOH, it might be good for users to know that that's being used in the DSI. On the performance transparency piece, this is specific to predictive decision support interventions. And really what we're looking to try and give users a sense of is how is the model intended to be used? What was the training data set or the example data set that was used to train it? Was the model trained for fairness? Was the model trained for validity? And potentially were these dimensions evaluated in local data? So those are really the performance and technical information related to the predictive DSI. And then last but not least, on the organizational transparency, we're looking to understand how well does organizations who develop predictive algorithms, how well do they manage risks related to those predictive algorithms? We know that the NIST AI risk management framework came out just a few months ago. And we've modeled a lot of our requirements based on what that NIST document outlines, and I think is a really important foundation for what we're requiring there. Okay, next slide, please. Okay, so big takeaway on this slide, really the source attributes requirements. Source attributes are ONC regulatory speak for ingredients. What are the ingredients of the decision support intervention? What are the ingredients of the predictive DSI? We have come up with a number of categories of information that we think it would be important for users to know. And the idea here is how can we shine transparency on the ingredients of a predictive DSI so that this concept of nutrition labels, which if you've been following the space closely, has taken hold and I think is a useful metaphor, if not more than a metaphor, for how this kind of information could be helpful to clinicians and to others within a health system that are monitoring and evaluating the use of these kinds of decision supports. I mentioned the supportive of health equity by design piece, as well as the additional enhancements I'll just touch on. We would require that certified health IT developers enable users to author and revise capabilities for source attributes beyond what we require, as well as require certified health IT to support feedback loops so that users of DSI could indicate whether or not any particular DSI was helpful to what they were trying to achieve. So those are the broad strokes on technical and performance. We can go to the next slide, please. Okay, so the two sides of the puzzle that we've been speaking to, the technical performance and then the organizational practices, is really how this breaks down. I mentioned risk, and we've got a set of requirements for those organizations that develop predictive decision support interventions. We would require that certified health IT developers that self-develop predictive DSIs come up with risk analysis, risk mitigation, and governance plans. Essentially, we think, and experience with the financial sector in specific has indicated that even when you know how an algorithm was developed, even when you know what it's supposed to do, even if you've got retrospective or prospective studies on how it performs, there's a need for ongoing risk management really across the life cycle. And so we rely pretty heavily on some documents and some concepts that were started over in the financial sector. And then as I mentioned, the NIST AI risk management framework really has a lot of concepts in there that we rely pretty heavily on. But at a really basic level, what we would require is that developers employ or engage in intervention risk management practices. And they would then need to report at a summary level what those practices are and make that information publicly available. We would require more detailed information be available to ONC when and if we ask for it. But I think regardless, this is another area of transparency that would help improve overall trustworthiness. Next slide. Okay, this is just real quick. This is just kind of further confirmation that we've relied pretty heavily on the NIST AI risk management framework in case you had any doubts. There are 8 kinds of risks that we think developers ought to be paying attention to. So when they analyze and think about mitigating risk, these are the kinds of risks that we think they ought to be looking at, or some of the characteristics that they should be thinking about. So we do get fairly detailed in trying to help people understand. And I think across both the intervention risk management proposals and the source attribute proposals, we do try and balance flexibility with prescriptiveness. We know that a lot of this is a moving target, it's ongoing in its evolution, and there are not well-established standards. I think NIST thankfully came out with their document when they did, because that was a very well put together, thoroughly analyzed, and a lot of public input was gathered across the sectors, because it's not specific to healthcare. And really what we've tried to do is take the general conceptual framework that NIST put together and tailor make it to predictive decision support in healthcare. Okay, next slide. All right, so a few questions that we would love for this group to have input on. Source attributes. Should patients have electronic access to source attributes? As I mentioned, there are 14 source attributes specific to predictive decision support intervention. Right now, we're proposing that information be available to users, but we have a number of questions in there around the utility of whether those should also be available to patients, as well as the public. We could easily envision patients having utility from accessing those source attributes, as well as the public having access to those information. The other piece is whether or not there are any source attributes we left off the list, or if there are source attributes that you think are kind of superfluous to instilling trust and trustworthiness. So would love any feedback that any of you have on these questions. And we do have some questions on feedback loops, probably less important to this group. So next slide. Okay, so to try and bring it home, we think that the requirements around DSIs and predictive DSIs would benefit patients, their care providers, as well as developers and the industry at large. I think at a really basic level, as I tried to say at the beginning, we think that our proposals would optimize the use of high quality predictive models in healthcare. And if that's the case, then patients are undoubtedly going to benefit, because they will just have important technology being leveraged to manage and improve their care. But we also know that we can't just deploy these things and think they're going to work on their own. And that's why we have these transparency requirements in there, so that there's a check to make sure that these things have been trained for fairness, for example. We do think that the widespread use of high quality predictive algorithms would have a demonstrable impact on preventing errors and harms, as well as just improved decision making. And hopefully the requirements that if they are finalized as proposed would be in place to catch algorithms that may have bias or inequities baked in, would catch those before they get deployed, or before they're deployed widely. And then last but not least, we do have some commentary in the proposed rule that would clarify patients' underlying access to this information. And I think to briefly summarize, and I'm happy to put it in the chat later, the specific citation in the regulation, but we do talk about in the proposed rule and point to existing guidance from OCR around whether these source attributes information would be available to patients for the same reasons that other information is available when it's considered part of the designated record set. So I'll include a link to that so you can have a closer look at that. Obviously, for providers, a big portion of why we're doing this is to improve the trustworthiness of predictive models, and we think this will go a long way. And if it's trustworthy, it'll just be used more, and we think that will be a positive for everyone. And then for industry, I think it's important to note that one of the really big things that's going on today is there are some algorithms out there that are really good and they're really important, and they will improve patient care at scale. But there are other algorithms out there that are not good and that are of low quality and that are no doubt hurting patients today. And right now, we just can't tell the difference between the two. And so if you're a developer that has a high quality algorithm, you're not necessarily seen as any better than the other developer who has a low quality algorithm. So we think this will go a long way towards creating information or addressing this information asymmetry. We also think that these requirements could have a much broader second and third order effects. So if we have this information and it's broadly available at scale, then we can do a lot more research. We can do a lot more with the information, and hopefully we can improve these algorithms on much tighter turnaround cycles. And with that, I will go ahead and kick things over. I think the next slide is over to my colleague, Mike.
All right, there we go. Hopefully everybody can hear me. Thank you, Jeff. So we're going to pivot a bit and talk about information blocking. So that's, again, broader than the certification program. It affects actors or entities that are participating or aren't participating in the certification program. They may use certified health IT. They may not at all use certified health IT, but are still covered by information blocking. So the way we're going to approach this is we're going to kind of level set a bit, talk a little bit about what is information blocking, and we'll talk a little bit about the proposals in the rule, a few of them. And then we will talk about enforcement. How is compliance monitored? How is information blocking enforced? And then after I finish that, we're actually going to turn back and then talk about how to comment, how to learn more about the rule if you want to, and how to comment on the rule, and then just provide some general resources available. And Lana will walk you through those parts. I'm going to walk you just through information blocking, and hopefully we'll still have time for some questions at the end. Okay, next slide. So here's the definition of information blocking. This is essentially the definition given to us by Congress, except for that part that you see crossed out, which we're removing. And we'll talk more in a couple slides what we're removing, but essentially it was a limitation that was placed on the information blocking definition. It was limiting the definition of EHI really to just the US CDI. So we've talked a little bit about the US CDI today. Version 3 being proposed. This was version 1, so it was just those data elements, and didn't matter how they were represented. But that is no longer the case when it comes to information blocking. It's all EHI. And we'll talk a little bit about what that definition is, like I said, in a couple of slides. So we'll break this down next. So next slide, please. So this is really what that definition breaks down to. There are certain elements of information blocking. So you got to be an actor, and I talked about how it's really broad. We're not going to go into that again today. At the end, there'll be a end of this entire presentation, like I said, a resource slide. You can go to that slide, go to the Cures rule. We have webinars, a lot of fact sheets, explanations of that. But generally speaking, there are developers that participate in the program. There are also health information networks, health information exchanges, which are defined the same now based on the final rule. We'll actually touch on that a little bit later in terms of how comments can inform a final rule. And then lastly, it's healthcare providers. Now that's broad. So that's not just your hospitals and some of your physicians and clinicians that participate in the Promoting Interoperability program. Those are labs, those are pharmacies, long-term post-acute care facilities. So it's a much broader definition in terms of who's included in the healthcare provider definition than comparative to those who participate in the certification program or use certified health IT. Okay, EHI, we're going to talk about EHI. Next slide, what that is. We're not ready to go there yet, but because I'm going to give you a couple pointers on the other elements of information blocking. So interference, So it has to rise to a level that interferes with access, exchange, or use. And that can even mean just materially discourage access, exchange, or use. It doesn't actually have to interfere with it. It could just discourage your access. So you want to keep that in mind. And we also issue we also issue what are called frequently asked questions. I saw a note in the Q&A, and we'll try to stay cognizant of that not to use acronyms, or if we do use acronyms, it would be good for us to repeat what that acronym stands for. So FAQs are frequently asked questions. And so we've issued over, I think, 50 of those now. A lot of them focus on what would likely or would likely not be an interference. And then we also talked about in the rules some of those actions that could be an interference, or we would think would likely to be an interference. Then knowledge. So depending on the actor, they have to have a specific intent. So for health information networks and exchanges, as well as developers of certified health IT, they have to know or should have known that the practice was likely to interfere with access, exchange, or use. Comparatively, healthcare providers must know, and it must be unreasonable, the practice that they're participating in would likely interfere with access, exchange, or use. Another key point, again, embedded in the definition given to us in the statute, is it not required by law. So if a law required a actor not to send the information, then it wouldn't be information blocking. And then lastly, where we were, Lana mentioned in the beginning, where we've been focused in this rule and in the first rule for the information blocking regulations, is identifying reasonable and necessary activities that are not information blocking. We call those exceptions. And this rule focuses both on the actor definition as well as certain exceptions. So now we can move to the next slide. So this is the definition of EHI. It aligns with the HIPAA rules, if you're familiar with those, in terms of what you as a patient or caregiver would have a right of access to under their regulations, which is EPHI that is included in the designated record set. So EHI is similarly defined, including what would be included in the designated record set. So depending on who is holding that at the time, that's an actor under our rule, for example, an EHR developer. And it would apply more broadly than whether or not it was just a HIPAA cover entity, as I just explained, was holding it. Okay, I think we can move to the next slide. And again, here are the 8 exceptions I mentioned that we focused on in our last rulemaking. In this rulemaking, we are proposing to modify 2 of the exceptions, the content and manner exception and the infeasibility exception. And as I mentioned, we'll go a little more into detail on those. So next slide. All right, so we're going to shift and talk about those proposals in this rule. So next slide, please. So definitions. Primarily, we focused in this rule based on feedback on the offer, what it means to offer health IT. And what approach we've taken is to propose certain exceptions, again, of actions that wouldn't meet the definition of offer. And why that's important is the definition of health IT developer, certified health IT, includes offering health IT. And that's directly from the statute in terms of who's covered under information blocking. So in this rule, we're trying to provide some clarity to those who are wondering whether their actions are going to make them an offer of offering health IT and thus a developer of certified health IT. So we're trying to provide some certainty there related to that. Then we have exceptions that I mentioned that we're focused on. So 1 revised, 2 new. We're going to focus. There's one is a bit of just a minor change in terms of what under the infeasibility exception, focusing on uncontrollable events. We're not going to spend time on that today, but we will talk about the other 3 proposals. And then lastly, we have some requests for information, again, to that offer of health IT, whether there should be additional exclusions besides the ones we proposed. And then again, if there's any additional practices under the TEFCA, so the Trusted Exchange Framework and Common Agreement, that's that acronym you're seeing there on the screen, stands for. And then lastly, we'll talk a little more about an RFI. So as was mentioned earlier with these 3 RFRs, and it was mentioned earlier by Lana, RFIs are different than actual proposals. We're looking for information from you that we can use to inform future actual proposals. And then those proposals go out for comment in a regulation. And then we take more comment on them before we finalize them, or choose not to maybe withdraw that proposal, depending on the comments. Okay, now we can move to the next slide. So third-party modification use. And I think this might be a time to mention, an overall approach for us when it comes to overall approach you should take even to any times you're thinking about commenting on a regulation. It is important for the agency to hear both positive and negative feedback, and negative being, constructive criticism or just outright disagreement with the proposal. But similarly, we want to hear positive. So sometimes you may not think on its face a proposal affects you directly. For example, this proposal and the other 2 that I'm going to talk about are really focused on providing more certainty for actors, so those who are actually covered under the rule. But you may want to look at it from the angle of, well, does this reduce my access to EHI? So that's the way I would suggest, from if you're a patient or caregiver, to think about it. Or does this help you better understand the rule and when you should and should not have access under the information blocking rules? So that's kind of the overview type of approach or framework and how you should think about these proposals, because you might again be thinking, well, this doesn't directly affect me, but it may indirectly affect you because these are exceptions. And so the way they work under information blocking is an actor would use this exception to limit or not provide access, exchange, or use of EHI. So in this particular one, what we're saying is if somebody wants to modify, and so what we mean by modify is to create or delete information in the record, so that designated record held by an actor. What we're saying here is currently under the regulations, a actor would have to prove under the feasibility exception that under the circumstances that was not feasible. Then there's like 6 criteria that have to be considered. And instead, what we've said here in this particular circumstance, so when it's not a business associate who's or the covered entity themselves asking to make modifications to the record, if it's anyone else, they can use this proposed condition to say no to that, to not do it. So that's generally, they may still have been able to say no under the current exceptions. I want to be clear about that. And I just gave an example with the infeasibility under circumstances, but what this is doing is providing more certainty to them in that particular circumstance in which if they are the actor, for example, an EHR developer that supports the EHR for a covered entity, a healthcare provider, then they could, and this is the type of request they received, they could potentially, if this is finalized, this exception. So you need to want to think about that. Does that have any negative impacts for you? And whether you want to express those through a comment on the rule. Okay, next slide, please. So this is a exception again for actors to try to provide more certainty. It is similarly focused in that same space of feasibility under certain circumstances. So what we're trying to do here is provide more certainty. So for example, now if an actor offered a certain way to provide the EHI and the requester resisted or didn't agree, then they would work through the content and manner exception. And in each of those, there's alternative manner. The requester has to agree for the actor to get the benefit of that exception. So for example, yes, give it to me through certified health IT, and the requester agrees to that, and that's how they do it. And then there's certain provisions and when they do it that way in terms of the reasonable fees and licensing provisions apply. But if they don't agree, the actor then may proceed to the infeasibility under circumstance. Again, those 6 factors, of which one is whether they could have provided it under the content and manner, and then there's a weighing of those factors. And to get the benefit of that exception, they would have to meet the criteria that why they didn't provide the EHI. And so what we're saying here is we're trying to provide a little more certainty that if they go through that process and still can't reach agreement, including using two of the alternative manners is a potential proposal instead of all three of them. And then they do this, which is number 3, which is or essentially they don't do this, I should say. They don't provide the same access that's being requested, access, exchange, or use, to a substantial number of individuals or entities that are similarly situated to the requester. And so I've highlighted on the screen here the 4 key components to that. So they have to currently be providing this manner. So it wasn't something they did, years ago and don't support anymore. It would be something they're currently doing. And then 2, it has to be the same. There can't be any customization necessary. 3, substantial number, we're requesting comment on that because substantial number could be different depending on the actor. A large healthcare system, substantial number may be different than a small healthcare provider in a rural setting, for example. And then similarly situated is also very key. One of the things we said in the rule, in the preamble about this, that just based on the status of the requester by itself shouldn't be the reason to determine whether or not they're similarly situated. In particular, we said individuals, for example, a patient or an entity or a healthcare system, that just because of that status alone shouldn't be the reason why you determine they're not similarly situated. So we've requested comment on that. Requesting a comment on the whole proposal, and I would, if I was going to identify any particular instance for you, is whether or not any of these terms or these proposals, if you feel like it somehow changes what the current framework is in a way that makes your ability to have access, exchange, or use of EHI more limited. So we can move to the next slide next. And here we have what's called the TEFCA condition. This falls under the manner exception, which is a content and manner exception. We're just renaming it because before, content was limited by time. Like we were just talking about the definition about how for a period of time it was just USCDI, now it's all EHI. Since that's no longer the case, we're also modifying the content and manner exception because content in all cases now will be all EHI or limited to what is requested within that. So now called the manner exception proposed and the TEFCA condition. So what this is essentially saying is entities have agreed to participate in TEFCA. And since they've agreed to participate in TEFCA, they should agree to accept the EHI that they request through TEFCA connectivity services. So this doesn't apply to anyone who hasn't chosen to participate in TEFCA. So if you had a third party, you chose to authorize a third party to have access to your EHI, and a healthcare system was participating in TEFCA, they couldn't necessarily make that third party join TEFCA to get access to your EHI. That's not how this condition works. It's for those entities that all voluntarily chose to join TEFCA to embrace the TEFCA connectivity services for access, exchange, and use of that data. I will put a plug in. It would be good, or it is beneficial for picking and choosing third-party apps to provide you access to your EHI that participate in TEFCA. I say this because we have proposals and frameworks around TEFCA that requires those third-party apps to have certain privacy policies and certain security policies. So they're to participate in TEFCA, they're going to have to meet certain privacy and security requirements that may not apply otherwise because they're not. Many times those entities aren't covered by the HIPAA rules or other rules that would require certain privacy and security requirements. So plug for using entities that choose to participate in TEFCA later on for providing individual access to EHI. Next slide, please. So This is an RFI. So again, RFI means request for information. So this is an actual proposal, unlike what Jeff discussed with you under the certification program. But it could inform, future change. If that proposal was finalized, this could potentially inform. And as we mentioned, we have another rule planned for release in November. So this RFI information that we got back from that may inform a future proposal in that rule or a different rule in the future. Related to other actions we could take in terms of functionality and requirements under the certification program. So I'm going to leave it at that for this one because we definitely want to spend a decent amount of time on how to submit comments. So I want to kind of move through this a little more quickly and get back to Lana to talk to you about that. So let's move to the next slide. So we've gone through the proposals in the rule. So this is just more information for you about complaints and enforcement when it comes to information blocking. So next slide, please. So this is a screenshot of where you want to go to if you want to report information blocking, or if you have a complaint about health IT safety or certified health IT. So this is really important from that perspective. If you have any of those type of concerns or complaints, you want to go to this webpage and use one of the portals here to submit your feedback and concerns to us. Next slide, please. And this just shows you, it's available on our website, how once you submit that information from a information blocking side of it, how it's going to proceed through ONC. And you'll get notifications throughout the process from us in that regard. So just want to make you aware of that. As you can see, OIG has a lot of the more scope and authority here. Ours is really focused on corrective action for developers and only for developers of certified health IT under the certification program. Next slide, please. Consequences. We talked about all those, who are actors, and they have different consequences. ONC is working on a rule about appropriate disincentives with the department. That is targeted for September release of this year, September 2023 release of a proposed rule. As it goes to developers, certified health IT and exchanges and networks, the Office of Inspector General is in the final rule stage. That rule is under review by the Office of Management and Budget, OMB. It's the last stage before that rule comes out and publishes. And once it's publishes, there's a delay in the effective date, and then it becomes effective, the provisions of that rule, and they can begin enforcement. Next slide, please. This is to make you aware of part of the the budget process. ONC has a request in there to have, really it's the department has a request for authority to issue what are called advisory opinions. And these can be good for patients too. So you could ask us, based on a set of facts and circumstances, was an actor potentially committing information blocking? And then we would analyze, we as a department would analyze that situation and provide feedback on that. So next slide, please. And I will turn it back to Lana to talk to you about opportunities to learn more about the rule, as well as how to submit a comment. So Lana.
Thanks, Mike. All right, well, let's get into these opportunities to learn more about the proposed rule. Next slide. Okay, so there are already some great resources that I want to highlight on healthit.gov. And this is the URL you're going to want to go directly to. So healthit.gov/proposed rule, all one word. And we have several fact sheets there. You'll see here the list of topics, as well as some measurement spec sheets. And that is for each of the 9 proposed insight condition measures. Next slide. I want to talk a little bit about the high-tech HTI1 proposed rule task force. But first, I want to tell you what, some of you might be asking of what is the high-tech. So the high-tech was established in the 21st Century Cures Act and is governed by the provision of the Federal Advisory Committee Act, so FACA. Spelling out the acronym, which sets forth the standards for the formation and the use of federal advisory committees. What does the FACA do? Or what does the HTI do rather? The HTI recommends to the national coordinator and to us at ONC policies, standards, implementation specifications, and certification criteria. And the HTI is focused on 5 target areas that are defined in the Cures Act. So those are design and use of technologies that advance health equity, use of technologies that support public health, interoperability, privacy and security, and patient access to information. So we have an actual HTI1 proposed rule task force within the HTI. And this has started this year, and their main goal is to evaluate and provide draft recommendations to the HTI on this rule. And it's spelled out here again, the health data technology and interoperability proposed rule. So all of the task force meetings are open to the public. So this is why I'm mentioning it. And the registration and meeting materials can be found at this URL. And also you can search for it on our site. Next slide. Okay, so one thing I would like to encourage all of you to do is not to miss our upcoming webinar next week on June 8th. That we have yet another overview of the proposed rule and a Q&A session, questions and answers. So we expect to have a significant amount of time to answer questions that you may have. And if you cannot make it, all of our past webinars on the proposed rule can be found at this URL, again, healthit.gov/proposed rule, which is on the screen now. Next slide. So now I'm going to talk a little bit about the importance of public comments and how to comment on the HTI1 proposed rule. Next slide. So looking at the public comments, I just want to stress the importance of getting public comments from a wide variety of stakeholders, including patients and caregivers. During the 21st Century Cures Act rulemaking, ONC received approximately 2,000 comments from the public. And those comments truly formed the basis of the 21st Century Cures final rule. So for example, in the 21st Century Cures Act proposed rule, we proposed definitions for health information network or a HIN and health information exchange, HIE. So that we revised based on public comment. And I'm going to show you an example of that. Next slide. So you'll see here the example of the public comment that is informing our final rule on HINs and HIEs. The 21st Century Cures Act proposed rule definition on the left side, and then on the right side, what the final rule definition was. And I won't read all these to you in the interest of time, but that is something you can go back and look at the specifics of how that informed our final rule. Next slide. All right, so down to the nitty-gritty, how to submit a comment online. Here are a few ways to find the HTI1 proposed rule, and there are full instructions of how to submit a comment in the proposed rule itself. So as you see on the right hand here from the HTI1 proposed rule on the Federal Register, you click the Submit a Formal Comment button, which is the green button in the center of the screen. You can also find this at regulations.gov and search by the Federal Register docket number, which is right there, the 2023-07229. Next slide. So you may submit text in the comment field or upload a comment document or both. Whatever that you select, whatever works for you. We provide on healthit.gov a template for the public to use if they choose when submitting their comments. And so here is just more instruction on how to upload a completed comment template or another type of file. You would click the green button at the bottom left, which says Add a File. So after clicking the Add a File button, you may also want to look at the attachment requirements, which actually show the supported file formats and size per comment submission. So that just wanted to point that out as well. Next slide. So in submitting your comment, you're going to enter your information, and you're also going to remember to select the I read and understand this statement above box. So we've highlighted that, and then you select the submit comment button. What to consider, I think there are some things that I just wanted to point out, that any comment for us is helpful, even if it's shorter, and even if it does not cover the whole rule. Just focused on, one section or one provision, but we want to encourage anyone to submit a comment on any part of the rule. And also it's important to note that we review all comments. Next slide. So now I'm going to shift gears a little bit just to highlight some of our general information and other resources. Next slide. Back in 2018, we created the ONC Guide to Getting and Using Your Health Records. It's also called the Consumer Guide. And this was just a way of us responding to comments we had gotten from some of our stakeholders of, what about a resource for patients? How do patients understand, getting, using, and checking their health information? So this is one of the places that we encourage people to take a look at. Go there. It's an online resource that gets updated, and we would love to have anyone look at it and provide feedback. Next slide. I also wanted to just highlight that we have an upcoming webinar this Monday, June 5th at 2 p.m. And it's part of our policy and practice series. So it's on supporting ready patient access to test results. And we have an excellent panel. So I hope that all of you can join us for that as well. Next slide. And this is just a long list of some of the ONC and HHS resources that we wanted to highlight, including the guide. We also have several things for patients, patient access videos. We have API training modules for folks that are interested in knowing more about that. We also have some infographics. Even for clinicians and care teams, we created a patient engagement playbook, which is part of our larger health IT playbook. We have a guide to privacy and security. And then we also have many resources on the ONC's Cures Act final rule, as well as information blocking. And last but not least, on TEFCA, our Trusted Exchange Framework and Common Agreement. And I put that link in the chat as well. Next slide. So to wrap up, here is how to get in touch with ONC. I just want to thank you all for your attendance, and I will hand it back over to Mike. I know a lot of questions have been answered in the Q&A, but Mike, I think we have about 8 more minutes for questions if you want to field those.
Yeah, great. Jeff's on. We have some other colleagues on as well, so we're happy to take questions in the chat or live. Do want to reiterate, June 20th is the end of the comment period. So you want to get your comments in by then. You still have a good almost 3 weeks. You'll have to end of day on the 20th to do it through regulations.gov. Honestly, I'll say this. I don't know if it's ever been down on a day of a comment period ending, at least not of our rules, but it may behoove you to try to get it in before that date. The 19th is a holiday. Technically, the comment period would have ended on the weekend because we had published on April 18th. But because of the holiday, it moves out. Because it ended on the weekend and because of the holiday, it moved all the way out to the 20th. So, as it is with when you were back in school, which is a long time ago for me, don't always wait till the last minute because you never know if your computer's going to crash or the website's going to crash. So try to get in maybe a couple days early. So we can take any questions now. Again, some of them, if we can't answer them, it behooves you to, again, submit that as a comment on the rule. These slides, maybe one of my colleagues can jump in how quickly they would be available, because I know a lot of you are probably thinking this would be a great resource to have handy as you prepare your comments on the rule, and just to check again, like, okay, where do I go to submit those comments? Because I know there was a lot of helpful slides in terms of links to go to and how to do it and the topics and also the acronyms. We heard a lot about that. Rightfully so, we use an acronym. We might have said what it meant on slide 1, but we weren't on slide 1 anymore. And I can understand how you're not sure what that meant anymore. So hopefully with me just talking now, somebody will be able to come on and say when they think these will be available. Oh, there you go. So Cannon has put in the chat that we're hoping these will be posted by Monday. So we have, so there's a, so we appreciate that. There's a comment about, would and I assume the deadline they're talking about is the deadline for submitting comments, because I just had mentioned the June 20th. We've actually even received some letters on that. I'm not in a position to give you a formal response right now, other than that the comment period is still the 20th. It does support the proposed, I can tell you that it supports the proposals in the rule in terms of a lot of these proposals are time sensitive. If you've looked at them, like USCDI as discussed by Jeff, some of the API ones, some of the other standard ones, we say that they have a certain period of time, those that are developers, in which they're going to have to get this get their products updated to be able to support these new standards. And the sooner we can get a final rule out, so they know what the final policies are and the final requirements are, the quicker they can get that done. And actually they get more time then to get that done. So that's obviously driving some of our us in terms of how quickly we want to get to a final rule, get those comments in, because we're going to need time to review all those comments before we can publish a final rule and get through a bunch of review as well. But sorry, couldn't answer that directly with a yes, no. Right now, what you do need to know is the comment period is the 20th, and that hasn't changed as of right now. Is that it? I don't know. I'm just waiting.
Mike, I think there might be a verbal hand up. That's what I'm seeing, but I'm just trying to.
I don't see that on my screen, so I don't
Okay.
know. Maybe it's just my screen.
Okay.
Is that under the Q&A? I'm just looking in the Q&A and I see Rachel's responding to a comment there or question there, so I'm not sure where that's at. But yeah, we're happy to answer that if somebody wants to
Why don't we
provide
have
technical support to them.
Tom, why don't we have you let Susanna Lipscomb unmute her line, and then she can ask her question.
Thanks, Cannon.
Susanna, you might be on mute, but you do have the ability to unmute now. All right, if we can't hear Susanna, perhaps we should
She
move on
doesn't
to-
have a question, I don't think. I think
Perhaps
she
we-
just put in the, yeah.
Perhaps we should move on to Nancy Lush. And again, Nancy, you should be able to unmute yourself now if you would like to ask a question.
In the meantime, there's a question in the Q&A box that I can take.
Okay, Jeff.
Yeah,
Sounds
if an EHR developer or vendor doesn't provide AI or ML CDS, is the proposal that EHR vendors start supporting AI ML DSI? Thanks, is the question. That is a great question. And I should have made known at the beginning that the answer to that question is no. The way that we've constructed the decision support intervention revised criterion is that if the certified health IT developer doesn't plan to or doesn't support predictive DSI like technology, then they don't have to. In fact, the way that we've constructed the criterion is we have an attestation, and depending on if the developer attests yes or no, that would then send them down a path of additional requirements. So nothing in our proposal would require a health IT developer to support AI or ML DSIs if they don't currently or don't plan to. Good question.
Okay, I think we are at time. So I just want to thank everyone for attending and encourage everyone to go and review the HTI1 proposed rule and comment on it if you are so moved. And please note, as Cannon said, that the slides and the recording will be posted on the proposed rule section of healthit.gov. Thank you so much.
Thank you. Bye now.